Hello, I am Dr. Ahilasamy from Chennai. I am going to show a case of chronic cough for 3 months due to bilateral maxillary fungal ball or bilateral maxillary fungal sinusitis. It is not AFRS or polyposis. The patient is around 55-year-old female, non-diabetic, no immunocompromised state. You can see the coronal CT scan picture showing the opacity in the both maxillary sinus, and you can see the multiple density and hyperdensity in the maxillary sinus in the soft tissue cuts, and you should always ask for soft tissue cuts with HU values to differentiate from a ordinary sinusitis and a fungal pathology or any other pathology. Many scan centers they don't give, but you have to specifically ask. The rest of the sinuses like ethmoid, frontal, sphenoid are all normal. I am taking this case under local anesthesia with IV sedation. This is a diagnostic endoscopy. In fungal ball, you hardly see any pathology. There's a gross septal deviation to the right side, but I will manage without doing septoplasty if possible. First step is packing the nasal cavity and the middle meatus with a roller pack soaked with 4% lignocaine and adrenaline in the ratio of 1:1. That is, I take 10 ampule of adrenaline and that is 10 ml of adrenaline and 10 ml of 4% lignocaine. Keep on packing for 3-4 times till you get a good space. See, now even on the right side you get a good space. So I can avoid a septoplasty. But sometimes it may hinder in the post-operative care. If you feel that, you have to do the septoplasty. Now on the left side I am giving the sphenopalatine block. That's the only block I will be giving, and also on the right side also I will be giving the sphenopalatine block. With the sphenopalatine block itself we can finish the maxillary work. It is given with a 5 cc syringe, 23 gauge spinal needle, and a solution of 0.5% ropivacaine and adrenaline. You can see nice blanching. The only symptom in this patient is cough. I am giving the sphenopalatine block on the right side. Patient doesn't have a nose block or nasal discharge or anything. Of course, there would have been a post-nasal drip, which the patient didn't complain. That is the cause for the chronic cough. Now I am using the Ahilasamy backbiting forceps to take the lower one-third of the unsnare process. This is mini FESS, and now you can see the Parsons window. You enter into the maxillary sinus, that's called the Parsons window. Now you keep on widening the middle meatal androstomy. Always watch these videos on a big television screen. You will appreciate better. Do not watch on mobile only. You can't appreciate the beauty. So I use this cord suction. You can see a lot of fungal material inside the maxillary sinus, and now I am using the straight true biting forceps to take the posterior lip of the MMA. This surgery took around 15 minutes. I have edited to around 18 minutes or 19 minutes. You can see a lot of fungal material, greenish, yellowish material. I have given the patient preoperatively itraconazole and prednisolone for 4 days because the patient was in a hurry because she had a severe cough. Otherwise, I would have allowed to give for 1 week or 10 days, even up to 15 days. Here, the fungus has melted a bit because of the 4 days treatment. If you had even for 10 to 15 days, it will melt totally and it will be fully easily suckable. If you don't give preoperative itraconazole and prednisolone, you have to struggle more time in removing the fungus. Of course, one of the disadvantages doing under local anesthesia is you cannot give the washes. I am using the curved sucker to take out the fungal material. The fungal material will be sent for histopathological examination, KOH staining, as well as fungal culture. Of course, that doesn't change the post-operative management. Now I am using the malleable curved sucker to dislodge the fungus from the anterior part of the maxillary sinus. Remember, it's a bit edited video. See, now I am using 70-degree telescope. So you can see lot of fungal material in the anterior anteroinferior part of the sinus. So always work with a 70-degree and a 90-degree telescope for maxillary and frontal pathologies. Do not stay with 0 or 30 or 45 only. You will leave behind lot of pathology within the sinus. See, appreciate the field. Hardly any bleeding. It's like looks like a cadaveric field. Now I am going for the wet mopping technique. A roller gauze soaked in 4% lignocaine and adrenaline is inserted into the maxillary sinus, and like a mopping, floor mopping, I am just mopping the maxillary sinus, and that will mop and dislodge and anesthetize the mucosa, and do not injure the maxillary mucosa anytime. It will start to bleed or it will have a scarring post-operatively. Preserve all the 100% mucosa everywhere. Now I am using the curved sucker to do the wet mopping. See, I am dislodging. See, so much liquefied fungal material because of the itraconazole, and the fungal material non-liquefied also coming out along with the wet mop. Do it repeatedly till you get full clearance. Patients are very cooperative under local anesthesia with a good sphenopalatine block and a moderate IV sedation with fentanyl and dexmedetomidine. Of course, we don't do hypertensive anesthesia. Still, the field will be very, very good under local anesthesia. You can hardly appreciate any bleeding, almost like a cadaveric field. So the wet mopping gauze is removed, which is carrying out lot of fungal material. Still, see, there is some in the anterior and floor. Still, now I am using the malleable ring cutter to dislodge the fungal material. These are usually aspergillus or mixed fungal infection. These are not invasive mucormycosis. Post-operatively, they don't require fungal treatment. See, greenish. That's classical of aspergillus. These materials will be sent for histopathological and microbiology examination. Still more, I am widening the middle meatal andostomy by taking out the anterior wall. Still, because I couldn't assess that part. Now I could take more material. Some steps have been edited. I am working with a 70-degree telescope. If required, I use a 90-degree telescope also. Since the discharge of fungal material be sucked out with a curved sucker. Hardly any bleeding. That's the beauty of being under local anesthesia. And these patients will not require any post-operative nasal packing, and they will be discharged on the same day as daycare procedure. Again, I am using the malleable ring curette and sucker repeatedly to dislodge all the fungal material. You have to completely remove all the fungal ball, otherwise the disease will recur and the patient's chronic cough will not go off. So I use sucker to suck it. Now I am using my own design that knife and set decider. Now again I am doing the wet mopping technique. Still there is still some secretions, the fungal material and everything. Keep repeatedly doing. Hardly any bleeding and the sinus is almost clear. Finish it off with it. Now with the CRD telescope, beautiful cavity and no scratches on the terminates, septum, nowhere any bleeding. So these patients will not get crusting and sinus or anything. And now I am come to the right side. The same steps are repeated using the Nagashima's backbiting forceps, doing the mini FESS, that's taking out the lower one-third of the unsnare process alone to create a Parsons window. Liquefied fungal material is coming out because of the itraconazole and the prednisolone which I had used. Now you can appreciate the Parsons window. So with the curved sucker, I am just pushing the posterior part of the MMA to open it wide and lot of fungal material within the sinus. See, hardly any bleeding. That's a beauty. Almost like a cadaveric field. When there is no bleeding, there is less chance of injury to the other normal structures, less complications during surgery. No need for a post-operative packing and the patient can be discharged daycare. Now with the Nagashima's forceps, again widening the inferior part and the anterior inferior part of the MMA. When you leave behind the upper two-third of the uncinate, there will not be any synechiae between the middle terminate and the lateral wall. See, the greenish fungal material is just being scooped out with a sucker, curved sucker. This material will be also sent for analysis. Some are being sucked into the sucker, some will be sent for the analysis. See, all the antral mucosas are preserved on both the sides. That is very, very important for the good healing of the sinuses. See through, no raw bone is being exposed. Now I am using the malleable ring curette to dislodge the fungus from the anterior wall, anteroinferior wall, anterosuperior part, everything. Remember, the whole procedure is done under local anesthesia. I mostly do most of the nose and sinuses under local anesthesia as daycare procedure. Cost effective, less hospital stay, less complications, less post-operative sequelae like crusting, sinus, etc. We asked the patient to dose the nasal cavity with saline from the second post-operative day onwards. When you have a cavity or mucosa like that without trauma, no need for a post-operative cleaning also. By the doctor only, the patient nasal douche with nose blowing will clear out all the blood clots or anything from the nasal cavity. We hardly get any synechiae. Do not produce any scratches on the terminates, septum or anything. Still lot of material on the anterior part of the sinus which is being released. This is the liquid part of the fungal material because of the using of preoperative usage of the prednisolone and itraconazole. If I had used for 10 to 12, 15 days, then most of the fungus would have liquefied and will be very easily suckable. In this case, I used for only 4 days because the patient needed a surgery early as possible. Remember, I am working with a 70-degree telescope. Always work with a 70-degree telescope for maxillary work and frontal work. 30-degree and 70-degree, 45-degree telescope alone is not suffice. Some case you may require a 90-degree telescope also. Most of the sinus are cleared. Again, I am doing one more wet mopping technique on the right side. The curved sucker, I am doing the wet mopping to clear out everything, every fungal material, discharge, everything. Of course, already I have mentioned one of the disadvantages the local is flushing the sinuses with saline. Of course, you can do by putting an Foley's balloon in the nasopharynx, inflate, pull it, close the choana, and wash it, keeping a suction in the floor of the nasal cavity. A small drop of secretion is there. In the sigma area, zygomatic process area, that will be also sucked out. Now the whole sinus is clear, hardly any bleeding, and a very good MMA to visualize post-operatively. Now come to the 0-degree telescope. You can appreciate the beauty of the nasal cavity on both the sides. With the mini FESS itself, you can do a very big MMA and clear all the antral pathology. Do not injure the mucosa. This is the left nasal cavity. Thank you for watching. See you in another beautiful video. And you can contact me at my following address anytime. Thank you.